lung diseases. Okay. Start with the pulmonary. Start from this. So just quick terminology. In the past, they used to call it interstitial lung diseases. This term is not used anymore. They use the term diffuse parenchymal lung diseases. Now we'll explain in a few minutes why we changed the term. Okay. So interstitial lung disease or diffuse parenchymal lung disease is a term that almost includes more than 100 diseases. And they collect all these diseases under one term because these diseases share certain features. They share common clinical features. Most of these diseases, or almost all of them, present with progressive shortness of breath and exertion. They're not short of breath at rest. They're short of breath and exertion. Like hypoxemic after exercise. Very classic sign, symptom of interstitial lung disease or parenchymal lung diseases. I think this is one of the exact questions. They are not hypoxemic at rest until they are very advanced, very late stages. But early on, it's only hypoxemic on exercise, only short of breath on exertion. Okay, so that's the first feature that they share. The second thing is they share common radiographic signs in imaging. In chest X-ray, high-resolution CT, they have common similar features. The third thing, they all share the physiology on DFTs. So all these are restrictive, right, with high elastic recoil. Remember, restrictive lung disease are classified into restrictive with high elastic recoil, that's interstitial lung disease. Normal elastic recoil, that's neuromuscular disorders, or low elastic recoil, that's the chest wall. Okay, now let's just quickly talk about the pathophysiology and why did they change the term from interstitial lung disease to diffuse parenchymal lung disease. So if you look at the simple graph of the alveolar capillary unit, this is the airway, of course, this is the alveolar space, this is the interstitial space, this is the capillary, right? So in the past, it was believed that these diseases only involve the interstitial space. That's why they were called interstitial lung diseases, just because the interstitium is involved. Okay. Nowadays, we know that the process, the inflammatory process, starts in the alveoli first. So there's usually alveolitis or pneumonitis first, and that leads to recruitment of inflammatory cells into the interstitial space, which is normally free of any inflammatory cells under normal circumstances. So if you have injury to the alveolar cells, alveolitis or pneumonitis, then you have recruitment of inflammatory cells. At the end, there's some sort of repair to the injury, and that repair is either a full recovery with scar formation, or if there is a continuous injury, like continuous exposure to asbestos, for example, then it may heal by another mechanism. There are different kinds of repair mechanisms. It can be granulomatous or fibrotic, so it depends. But in general, the end process is usually accumulation of fibroblasts in the interstitial space, and then collagen deposition there, and then interstitial lung disease or diffuse parenchymal lung disease. That's why it's alveolar and interstitial. Sometimes there are also capillary involvement, especially in vasculitis. You have capillaritis, so it's not only interstitial. That's why they like to call it diffuse parenchymal lung disease, because the whole lung parenchyma is involved, not only the interstitial space. Okay. Now, how to classify diffuse parenchymal lung disease is probably the most interesting and probably the most complicated part. But we'll try to make it easier as much as we can. So the easiest way to look at diffuse parenchymal lung disease is to classify them into whether they are secondary to something that we know or something that we don't know. So idiopathic versus secondary to something, right? So the idiopathic ones are called idiopathic interstitial pneumonitis or pneumonia. IIPs. And the secondary one is secondary, right? So idiopathic interstitial pneumonias can be can involve actually the IPF, which is the most common, the idiopathic pulmonary fibrosis, which is sometimes called UIP, or usual interstitial pneumonitis. Usual interstitial pneumonitis is the pathologic definition, so it's a histopathology diagnosis. The clinical diagnosis is IPF, or idiopathic pulmonary fibrosis. It also involves something called RP, ILD, or BIP, respiratory bronchiolitis with interstitial lung disease, and discomative interstitial pneumonitis. There's something called also non-specific interstitial pneumonitis. There's something called AIP, acute interstitial pneumonitis, or sometimes Hamann-Rich syndrome. There are other like COP, which is the cryptogenic organizing pneumonia, LAM, lymphangial myomatosis, there's pulmonary histiocytosis, or Langerhans cell histiocytosis, right? There are a lot of categories under the idiopathic. Another one is called lymphocytic interstitial pneumonias or pneumonitis, so LIP. All these are idiopathic, okay? So we don't know exactly the main trigger to these conditions. The secondary ones are easier to remember because they're usually secondary to something that we know. So they could be secondary to genetic disorders like tuberous sclerosis, neurofibromatosis, and sometimes there is a rare syndrome called Hermansky-Gottlieb syndrome, which is interstitial lung disease or diffuse peritoneal lung disease associated with inflammatory bowel disease, platelet dysfunction, skin pigmentation, and that. So that's genetic. Right, that's number one. Number two could be secondary to occupational exposure, so occupational. And the occupational ones are subdivided into two major categories. Either it's exposure to organic material or inorganic material, and so that's organic versus inorganic. The organic ones also subdivided into immune-mediated versus non-immune-mediated. Immune-mediated, the big one is the hypersensitive pneumonitis, here, HP, which is called in English literature also. In Europe they call it extrinsic allergic condylitis. Same disease, it's hypersensitive pneumonitis. Non-immune is the big one, is the byssinosis, which we probably didn't need to know about. Anyway. Inorganic are the classic asbestosis, silicoses, and cold-water pneumoconiosis, and others. So these are. Pneumoconiosis can be also included in the occupational. Some people include it under the granulomatous disease, so we can classify it either way. So it could be secondary to immunologic disease or process. Like sarcoid is a big one.
Systemic sclerosis.
And all connective tissue disease associated with interstitial lung disease or diffuse parenchyma can be included under the immunologic one. So connective tissue diseases. Vasculitis is a big category under the immunologic one, right? Wagner, Pasteur, lupus pneumonitis, Church-Strauss, microscopic meningitis. All these goes under the connective tissue disease, right? The sarcoid is kind of unique disease, very interesting topic. And berylliosis probably with sarcoid. Because these are granulomatous, these sometimes granulomatous, sometimes not granulomatous. Okay. Also, you can get it secondary to cancer or malignant process. So it could be secondary to metastasis. Classically, lymphangitic carcinomatosis, which is hematogenous or lymphatic extracellular parenchyma. Or sometimes lymphomas can directly invade the parenchyma. Very rare, but may happen also. So that's cancer. The last one is iatrogenic, which is secondary to therapy. Chemotherapy is a classic one: methotrexate, antiarrhythmic, amiodarone, antibiotics, nitrofurantoin. All these medicines can cause. And of course, radiation therapy can cause also pneumonitis and can be included. So it's iatrogenic. Okay? So that's just a kind of quick scheme of the classification of interstitial lung disease. These are the secondary ones. Okay? Now we'll go quickly through the approach to interstitial lung disease or parenchymal lung diseases. So 3 steps. First one is the basic one, history, physical, basic workup. Basic workup includes chest X-ray, PFTs, and some basic blood tests, like citrate, maybe UA, something like that. So history, physical exam, chest X-ray is very mandatory in PFT, and others, of course. Okay. Second step is high resolution CT. Much more sensitive than simple chest X-ray. So if you have suspicion of interstitial lung disease or diffuse parenchymal lung disease, you go for high resolution CT. Sometimes high resolution can be enough for diagnosis. Sometimes you need to confirm it by biopsy or pathology. So the last one is histopathology.
Yeah.
So histopathology, you can get it through 2 ways, or 2 major, let's say. It's either bronchoscopic guided transbronchial biopsy, which has low yield most of the time. Sometimes it's adequate, but most of the time it's not. Or you can get like a big sample by doing either video-assisted bronchoscopic lung biopsy, VAT biopsy, or upper lung biopsy, OBL. Okay. So these are the 3 major steps. Okay. Now let's do quickly. Of course, the history and physical, you know. I mean, you have to ask about everything, the history, right? The symptoms first, to suspect parenchymal lung disease, you have to ask about exposure, smoking, history, drugs, chemotherapy, malignancy, everything. Symptoms of systemic diseases, lupus, whatever. You have to ask about everything. So I will not focus a lot on history and physical. They're very, very important. And actually, everything starts here. But I'll go more to the imaging and specific etiology. So let's start with the chest X-ray, simple chest X-ray. So a few things to remember on the chest X-ray. What is the pattern of involvement? Is it like more alveolar filling process or airspace disease, or is it more interstitial pattern, mainly like reticular, nodular, or something else? Is it like upper lobes mainly versus lower lobes? Is it peripheral versus central? Are there any other associated signs on the X-ray, like pleural effusion, lymph nodes, calcifications, dural sacs, anything like that? Everything helps. Okay. So the first thing is the alveolar filling, which is basically an airspace disease that anything that infiltrates or fills the alveoli can give you the alveolar filling, right? And this can be something simple as pulmonary edema, for example, can be blood. Could be pus, pneumonia, could be cells, like desquamative interstitial pneumonitis, could be anything, right? So if it's blood, if it's fluid, pulmonary edema, you have to remember these simple, basic mechanisms. Is it cardiogenic versus non-cardiogenic, right? If it's cardiogenic, that's like pulmonary edema, you have to deal with it accordingly, right? If it's cardiogenic pulmonary edema, that's a different story. We're not talking about that today. If it's non-cardiogenic pulmonary edema, then it's usually results from something called DAD, which is diffuse alveolar damage. So diffuse alveolar damage basically is damage to alveoli that results into capillary leak and non-cardiogenic pulmonary edema, right? Very simple. Now you have to remember that in order to classify DAD, you have to look for the underlying cause. So if you have SARS with DAD, that's ARDS. If there is no SARS criteria, then it's not ARDS, it's acute interstitial pneumonitis or Hamad-Ritz syndrome. Okay? Is it simple? So if you have diffuse alveolar damage with non-cardiogenic pulmonary edema, okay, in the absence of SARS, or underlying etiology like no sepsis, no pancreatitis, no severe burn, no underlying etiology that you can find, there's no SARS, and you still have non-cardiogenic pulmonary edema with diffuse alveolar damage, it's called Hamad-Ritz syndrome or acute interstitial pneumonitis. Okay? So that's the first thing, which is fluid. If it's blood, then you have to remember something that we call diffuse alveolar hemorrhage, or DAH, right? Diffuse alveolar hemorrhage is seen mainly in vasculitis, Wegener with Vasser syndrome, sometimes lupus pneumonitis, with capillaritis and vasculitis. All other small vessel vasculitis like Churg-Strauss, although this commonly microscopic cholangitis as well. Okay. So that's blood. The classic features, or the classic example is somebody who presents with bilateral alveolar filling pattern on chest X-ray with hemoptysis, drop in hemoglobin, maybe renal involvement, and that's classic diffuse alveolar hemorrhage. You should do something. Get citrate, ANCAs, ANA, check UA for proteins, casts, get nephrology, maybe get rheumatology. You may need pulmonary consult for bronch and lavage. And the classic finding in lavage is if you do more and more lavage, you get more and more blood, which is very classic of diffuse alveolar hemorrhage. If you have just simple bleeding from trauma or whatever, you should get less blood with repeated lavage. In hemorrhage, you get more blood with repeated lavage. Okay? And of course, if you send that for analysis, you get the hemosiderin-laden macrophages, which is basically macrophages engulfing the products of hemorrhage, right? Hemosiderin. So that's the second one. Third one is BUS, pneumonias. I'm not talking about it. Cells. Cells could be, so if you have cells filling the alveoli, could be eosinophils, and this could be acute or chronic eosinophilic pneumonias. Could be sloughed epithelial cells, which is called desquamative interstitial pneumonitis. Could be cancer cells, right? Which is a classic of alveolar cell carcinoma, right? So it could, which looks like pneumonia or alveolar filling in chest X-ray, right?
And what happens is it also gets proteins?
Yeah. Sometimes you have also proteins filling the alveolar spaces. Proteins could be, there's a disease called primary alveolar proteinosis, which is a defect in the GM-CSF, granulocyte monocyte colony stimulation factor, and that results into production of phospholipoproteins that accumulate in the alveoli. They present with diffuse bilateral alveolar filling pattern on chest X-ray. They have symptoms, shortness of breath. They have higher incidence of having myocardial infection in particular, and treatment is usually supportive. Smoking cessation is very important because most patients with alveolar proteinosis are smokers, and they have to stop smoking. Sometimes GM-CSF treatment is helpful, and sometimes they do whole lung lavage to get these proteins out, like immediately. Treatment is usually supportive. And the two infectious diseases that are associated with more proteins accumulation in the alveoli, histoplasmosis and BCD pneumonia as well. Just keep it in mind. Okay. What else could fill the alveoli? Sometimes there are something called alveolar microlithiasis. You have calcium crystals filling the alveoli. They cup up calcium crystals. Very rare. You need to know that. So that's the alveolar filling pattern. The other pattern is the interstitial one, which is, as I said, reticular, sometimes nodular, could be combined, reticular nodular. Each disease has its own pattern on chest X-ray. You have always to differentiate this from interstitial edema from CHL, or pulmonary edema, right? And is it upper lobe versus lower lobe? It's very important to remember this. I think you need just to remember, just memorize it.
Silicosis called usually upper.
So all occupational, or most occupational lung disease that Ahmed was mentioning are present with upper lobes, except one, which is asbestosis. So asbestosis is an occupation that involves more than uppers, right? Almost all connective tissue diseases associated with interstitial lung disease present with lower lobes, except one that presents with upper lobes, which is ankylosing spondylitis. Ankylosing presents with upper lobes. Okay. Now, most idiopathic interstitial pneumonias present with upper lobes, except the IPF, which is the most common one, that present typically with lower lobe, with subpleural involvement. So sarcoid, upper lobes. Hypersensitive pneumonitis, upper lobes. Langerhans histophagocytosis, upper lobes. LAM is diffuse, so LAM is like diffuse everywhere. Ankylosing is upper lobes, right? Silicosis is upper lobes. Cold worker pneumoconiosis, upper lobes. Asbestos is lower lobes. IPF is lower lobes. Connective tissue disease except ankylosing, all of them are lower lobes. Right? What else?
You covered.
We'll talk about each of them when we talk about several things. Central versus peripheral, again, very important. If you have somebody with infiltrate that is mainly central and it becomes less and less peripheral, how does it look like in chest X-ray? Look like what?
If you have one.
Like disease that involve central part more than peripheral.
Exactly.
Looks like pulmonary edema, right? So pulmonary edema, you have like central congestion, and then you go with the alveolar filling, more and more peripheral, right? So that's classic pulmonary edema, right? Non-cardiogenic as well. Interstitial can present that way. There are few diseases that present with peripheral involvement and less central involvement. You need to remember these as well. They are on board. There are some questions about them. So the cryptogenic organizing pneumonia is one of them. IPF is another one. It's peripheral, usually subpleural. Sarcoid is actually both central and peripheral. So it's very sarcoid is like a unique disease, so it may present with anything, but it may present peripheral as well. So peripheral, the big one is chronic eosinophilic pneumonia. That probably would be in the board question. Chronic eosinophilic, not acute, the chronic eosinophilic pneumonia. It's a classic, and they call them, by the way, they call it photogenic negative pulmonary edema. So it looks like exactly negative picture of pulmonary edema. Reverse pulmonary edema or photogenic negative pulmonary edema. Okay? Chronic eosinophilic pneumonitis, cryptogenic organizing pneumonia, IPF, and sarcoid. And sometimes drug reaction also comes. Okay?
Peripheral.
Peripheral. Okay, now we'll talk quickly about the PFTs, and that's again a board question in the mix-up. So PFTs, most of the time you'll see the restrictive pattern, right? There are a few diseases that may present with mixed, obstructive and restrictive. You have to remember them. Remember, histiocytosis is one of them. LAM is another one. What are the others? Sarcoid is another one, okay, and RBILD is the last one. So these for the board. I mean, the list is longer. No, LAM is the lymphangioliomyomatosis. LAM, histo, sarcoid, and RBILD, respiratory bronchiolitis, interstitial disease. Okay, so these are the myths. Of course, cystic fibrosis may present with mixed, tuberous sclerosis may present with mixed, rheumatoid patient may present with mixed, but at least for board, remember these four. Probably one of them would be the question.
Sure. Maybe then like so this is X.
We'll see. Because there's a question, I don't know. We'll see. So that's the BFT. You need to go.
The DLC, or I think.
So DLC is usually what? Reduced. Except one that you will tell us about next time. It's your homework.
Sure.
Okay. One chronic interstitial disease that presents with high DLC. Not acute, chronic. With high DLC.
Vascular component.
I don't know. We'll get that next time. Okay.
And the hypoxia of the glands usually after exertion, we do it or just adjust?
Yeah, that's hypoxemia on exertion. So okay. So we'll go very quickly through every single disease. Very quick. Because this is not like a lecture. It's very quick, but one day we'll go through the question. Okay? So I just wrote the disease that we need to talk about quickly. So IPF, the prototype of diffuse parenchymal lung disease, the most common one, right? Usually patients are classically more than 50 years age. Males and females are affected equally.
Equally.
Equally. What?
I thought females were more affected. Yeah.
We'll double check.
No,
You could be right. I don't know. I have to double check.
right.
So more than 50 years, they may have the classic features: shortness of breath and exertion, sometimes dry cough, mild constitutional symptoms. They usually present with gradual onset symptoms, right, over months, weeks to months usually, or years even. So it's very gradual disease. Sometimes could be associated with positive ANA, positive rheumatoid factor, hypergamic globulinemia. Not very important. Chest X-ray, usually peripheral pleural, and basal.
Okay, I'm happy.